And it looks like it's 12 o'clock. Thanks, Christy. And I'm going to introduce Rochelle. I know many of you have been in our previous sessions, but we're so excited to have Rochelle continue this series. And especially, I think everybody knows the fee schedule comes out, or the proposed fee schedule comes out once a year. And this is the changes that would go into place that in January of 2022. And often I haven't looked at the fee schedule. I will be very honest. I didn't look at it yet this year because I just depend on Rochelle like the rest of us. But normally they also ask for some comments. I'm sure Rochelle will hit anything that they're asking for comments on. And that's often something that they're considering doing, but haven't decided for sure yet. So with that, I will hand off to Rochelle Martin, who is an expert in the field and an attorney and a professor here at KU Medicine and Population Health. And very excited to have you today. And I'll let you get going.
All right, thanks. And let me just ask one question real quick while I'm moving things around. Are you still seeing the full slide view? Perfect.
We are. It looks perfect.
All right, good. Got like 5 or 6 different documents open here to help with questions. So I wanted to make sure I've got the right things out for you. Thanks for that introduction, Robert. So I love doing this topic, and I usually do it twice a year. And I do it twice a year, once when the proposed fee schedule comes out, which was just a couple of weeks ago in July. And it's an 1,800-page document. And of course, the physician fee schedule for Medicare is not limited to just physicians. It's everything that's paid under the physician fee schedule. So it's the professional billing fee schedule for next year. And so in this year's proposed rule, what I like to do is go through and look at what's being proposed and what would change and kind of highlight some of those things. So you all know what's likely to be in the pipeline. And sometimes there might be slight tweaks to it. Sometimes Medicare doesn't implement some of the proposals. But I wanted to go through, get some of your questions, get some of your feedback, because there are a lot of very hyper technical rules and requirements in this year's proposed fee schedule. See if I can answer those, but also give you some feedback from work that I've been doing with some of the national professional associations, reviewing this and providing drafting comments, questions mostly, back to Medicare on some of the proposals, because I read the proposed fee schedule, I read the final fee schedule every year. This was one year that, whether or not I was involved with professional associations, I planned on preparing at least my own individual comments, because there's just so much in here, so many technicalities, so many nuances that can get very complicated very quickly. So I want to share those with you and make sure you're aware and get your feedback, get your comments, get your questions. So we're not going to cover all of these topics, but to give you an idea of the different things that are in the physician fee schedule, telehealth, of course, that's the big one that we are going to cover this afternoon, and different proposals regarding telehealth and all of the changes that have come out in the last 18 months or so, really expanding, making telehealth more accessible in more geographic areas, in more originating sites. We'll talk about some of those rules. Now, evaluation and management services in the proposed fee schedule are not uniquely tied to telehealth. However, when they are provided as telehealth services, some of these rules and requirements are going to then extend into telehealth. A few others just to be aware of, depending on your provider type, and if you're doing some of these services in person, that you may want to go read. We're not going to cover this afternoon because they're a little bit outside the context of telehealth, but I think good to be aware of are therapy services and this incredibly complicated formula on number one, determining the units of time for therapy services, but also when to bill for therapy services under the name of the supervising therapist versus therapy assistants. And we're going to see a similar kind of formula in some of the evaluation and management services rules that we are going to discuss a little bit this afternoon. Colorectal cancer screening I put in here so you're aware. If you do any kind of GI services, that's a really important rule that's going to help close the gap on patient financial responsibility for those procedures that has been a huge issue for many years. And then there's some changes expanding coverage for RHCs and FQHCs on topics that we have talked about, transitional care management, chronic care management, mental health services, and also allowing providers of RHCs and FQHCs, the practitioners, to also be hospice attending providers separately for hospice care. So digging right in, we'll jump in with telehealth. And prior to this session, Christy and HTRC shared a video session with you that kind of outlined and went through an overview of some of the telehealth proposals. I'm more than happy to kind of revisit those at a high level and share some of the comments and the thoughts and feedback that I've been hearing from the provider community, that I've been hearing from professional associations. But before I dive into all of the rules, I wanted to kind of open it up to you all. If you've had a chance to read any summaries or watch that video, were there any telehealth questions that came to mind on some of the proposals in the fee schedule for this year? Okay, well, I'll go through and give kind of a high level overview. Please feel free to jump in with the chat and ask questions if you have them as I'm walking through this, and we can just pause as I go through the information and see if I can answer the questions. And if I can't, I'll go back to the proposed rule and we can send out that information after the session. So one of the things that is in the proposed rule addresses something that happened last year, I guess, or for when I say last year, the current fee schedule year, 2021, where we normally have two categories of telehealth services that are covered by Medicare. And when I say telehealth services and Medicare, I'm referring to that really technical definition where we've got restrictions on rural geographic areas, specific originating sites, lists of eligible telehealth services, so on and so forth. And the two categories that we normally have are category one, which are services that are similar to office visits, consultations, psychiatry services, and other services already on the telehealth list. That's where most of the Medicare covered telehealth services fall. There's also a category two, services that are not similar to those on the Medicare list, but that the public or the community is asking Medicare to consider to cover as telehealth, and why. And usually when there's a request to add a service as a category 2 telehealth service, it's not really related or similar to anything else on the list. The requester has to submit information on quality, efficacy of the service as a telehealth, how it meets the definition of telehealth, and there are some criteria there for Medicare to consider to make it eligible as a covered telehealth service. For 2021, we had a new category created, it's kind of a temporary bucket of telehealth services, and everything that's been added as a telehealth service since the beginning of the public health emergency that would not normally be covered prior to the public health emergency fell into this category 3 bucket. And the idea with that bucket originally was that when the public health emergency went away, so would the coverage of the telehealth service in that category 3 bucket, unless and until they met criteria as category 1 or category 2 to be covered permanently. And then some of those services in category 3, our temporary telehealth services, were designated as eligible to be provided via audio only. So it didn't require the audio visual component, but could be like a telephone call. And then some of those services would no longer be covered as telehealth immediately when the federal public health emergency ends. And some of those services would continue to be covered through the end of the calendar year when the public health emergency ends. So fortunately or unfortunately, it looks like we are likely to be into 2022 with the federal public health emergency status, which would mean those services in this category 3 bucket, all of the things that have been added as newly covered as telehealth would continue to be covered under our current rule until December 31st, 2022. So that's kind of a long way of saying how we got where we are today. Now, under the proposed rule, Medicare says those telehealth services that we have accessible right now temporarily, but that were not covered as telehealth prior to the public health emergency, those category 3 services, Medicare would continue coverage of those if this rule is finalized through December 31st of 2023. So even if, and hopefully it does, the public health emergency ends at some point until before the end of this calendar year or sometime next year, we would still have all the way through December 31st, 2023 for those services in the category 3 bucket. What that allows providers to do is to continue to collect data and information to submit to Medicare and try to get those services covered on a permanent basis as opposed to a temporary basis. Then at that point, for any telehealth services that haven't progressed from kind of the temporary category 3 designation to permanent telehealth, as of January 1, 2024, they would no longer be covered as telehealth. I'll put an asterisk on that because so many things can change between now and then. We have so much federal legislation that might affect telehealth in the next even few months. But assuming nothing else changed, that's what it would look like in the next couple of years for those services. So let me pause there. Are there any questions about how these categories work or what that would mean for ongoing coverage and flexibilities for some of these temporary services that we have access to right now?
Rochelle, remind me if I'm wrong, but it seems to me like last year was when they came up with this category 3.
They did.
You know, like we're not sure about it, we're going to try it out. And then it seems to me really that sort of promise till the end of 2023 is this same issue that we consistently have, which is how can I do something if I don't know if they're going to, you know, I can't implement something that I don't know if it's going to end suddenly. And so they're trying to give some level of consistency to, well, we promise you at least it won't happen until the end of 2023.
That's right.
In planning for healthcare services, a year is not enough, right? The investment and getting to the point of even profitability often isn't a year, but it does at least seem like they're trying. And I always feel like category 3 is a place that they're saying, well, maybe. So I guess my biggest question is, sorry to ramble on, did we see anything move from category 3 last year into category 1 and 2 this year? Have they made anything permanent?
Okay, so great question. And they didn't. And the reason they a couple of reasons. They made kind of this vague reference that they didn't receive any requests on time, which kind of suggested to me that they did get some requests to move from category 3 to 1 or 2, but because they weren't received by the deadline, they were not able to consider those. They also made a comment that of the services that they were reviewing, they didn't feel like they had enough data yet. So I would strongly encourage if you provide any of those services that are on category 3, meaning they didn't used to be covered prior to the public health emergency, they were added as covered during the public health emergency, you find them beneficial or you want to continue providing them, collect data on how it's worked, you know, anything from no call, no show, cancellation rates, improved access, any quality data showing benefit and clinical efficacy that could be submitted, and consider going to CMS and submitting a request with whatever data that you can collect. The deadline, I believe, is in February of each year to receive those requests so that Medicare has an opportunity to review it and include it in the proposed rule that comes out in July. So this would be a great time to be collecting that and compiling it for February of next year. But there were none this year that went from 3 to a category 1 or 2.
Because what we've seen as telehealth resource centers, and we try to push back on this, is the Congressional Budget Office, if they don't have data during COVID, they're using data from prior to COVID, and often they're using data on telehealth from for-profit companies. And what they're consistently reporting to Congress when they look at and to CMS, when they look at how much is it going to cost us to sustain this stuff, right, which is one of their biggest questions. They want this stuff to happen, but if they can't afford, if Medicare can't afford it, they're not going to do it. And when they're using inefficient data or data that isn't really reflective of the efficiency that we've hopefully gotten during COVID because of the amount of telehealth occurring, and they're using data from before when telehealth wasn't as efficient or effective or used, then they're going to have cost numbers that are too high, in our opinion, as TRCs, and they're not going to be able to extend it because they're going to say they can't afford it. And that's who Congress listens to. So I would really encourage associations and others, if you want to see things put onto Category 3, and especially if you want to see things moved into Category 1 and 2, make your voice heard, put in a comment, and by all means, if you have data, publish it, put it out there so it can be used as CMS is making the decision on whether they can afford to make some of this stuff permanent.
Yep. And the designation as categories 1 or 2 or 3 is on the telehealth list. It's an Excel file. If you go to cms.gov and you find the 2022 proposed fee schedule, there is an attachment to that, proposed telehealth services. Or you can look at the current year, 2021, in the spreadsheet, and it will identify which ones are category 3. So you know exactly which ones may be on the chopping block, so to speak, at the end of 2023 that could go away if we can't get enough data to support making those permanently covered. And a really good example of exactly what you were talking about, Robert, that comes to mind for me are audio only phone visits, something that was not covered before. But if there's data to show that a 15-minute phone call can prevent a 45-minute office visit and the costs associated with that, that's great data to show we're making services accessible. It prevents complications, it answers questions, it opens up face-to-face visits for other patients who need it, and it's cheaper.
You know, the other thing we want to stay away from is this idea that telehealth is, we want to show efficiencies and cost effectiveness, but the other assumption that's made is that we will revert to a system where they pay less for a telehealth visit than an in-person visit, because the data they have says it costs less to provide that. I don't believe it's true. I think anybody that provides telehealth doesn't believe it's true. I think they believe it's consistently about the same expense as an in-person. And all we'd like to see, or people would like to see, is that staying consistent between in-person and telehealth. That's probably, in my opinion, the biggest thing that's going to cause telehealth to go away after the emergency is over. If the reimbursement is so low that you can't afford to do it, then you're not going to do it. And that's the situation we were in before.
Right. Right. Okay, so this really touches on your question, Robert, on services that there were requests to add these as permanent, and I won't go through each and every code, but you can kind of see the general categories. And Medicare said no, either they, for the most part, didn't have enough data yet to add these on a permanent basis. Therapy procedures, the whole therapy category is going to be a big one as we wind down the public health emergency and figure out what our permanent telehealth rules are going to be, whether or not therapy continues to be allowed as telehealth, I think is going to be a big topic of discussion. So I'll pause there. Do we have any questions or comments in the chat? Oh, I do see one. If a state ends their emergency declaration at the state level, does the federal proposed extension to 12/31/23 still valid? Yes, it is. So these are Medicare rules that apply at a federal level and refer to the federal public health emergency. Where the states revoking, rescinding, expiring their state declaration of an emergency may come into effect is whether and how Medicaid within the state continues or discontinues some of their flexibilities for the state Medicaid services under those programs. It could also affect private payers and how they're handling telehealth within the state. It can affect licensure rules on who's allowed to provide telehealth within the state. But this 12/31/23 extension of Medicare Category 3 telehealth is federal and has nothing to do with the state emergency declaration statuses. All right, so let me move on to kind of a related topic, very intertwined with the traditional telehealth, and that's audio only services. So during the public health emergency, the Federal Department of Health and Human Services had the flexibility to kind of redefine what is allowed to be covered as a telehealth service, because the statute that was passed by Congress on telehealth defines telehealth as two-way audio-visual real-time communications. So because that was set by Congress, the department as an agency outside of a public health emergency doesn't have a lot of flexibility to change that audio-visual component requirement. So during the emergency, they did have that flexibility to create rules and allow audio-only services to be covered. There are ways that Medicare can add audio-only services in a slightly different way. One of the ways that they're proposing to do that are for certain types of mental health services. So to talk about this, I'm going to kind of back up a couple of steps on services that are already covered outside of the public health emergency, and then what this flexibility would do. So right now, there's already a federal law called the Support Act, and it's an act that provides support and coverage and payment for certain mental health services, particularly those related to substance use disorders or mental health conditions that co-occur with substance use disorders. And when telehealth services are rendered related to substance use disorders or related to co-occurring mental health conditions, under this federal law, in that limited, narrow box, the patient's home is allowed to be an eligible originating site. And that has nothing to do with the public health emergency. That's a permanent rule, okay? And also the geographic restrictions on providing those only to individuals in rural areas are waived, only for telehealth for individuals with substance use disorder or treatment for co-occurring mental health conditions related to substance use disorder. That's already covered, okay? So then we had something called the Consolidated Appropriations Act that would expand that coverage not just to mental health conditions co-occurring with substance use disorders, but the diagnosis, evaluation, or treatment of any mental health disorder, even if not co-occurring with substance. I'm sorry, let me make sure I said that correctly. Diagnosis, evaluation, and treatment of mental health disorders, whether or not they co-occur with a substance use disorder. And so I think of this, I'm very, from a coding perspective, I think of this on the claim form as the previous coverage would have a diagnosis code connected to some kind of use, abuse, substance use disorder, as well as a mental health diagnosis like anxiety, depression, so forth. But under the Consolidated Appropriations Act that expanded that availability of telehealth to all mental health disorders, then we don't have to have a substance use disorder diagnosis on the claim for these to now be covered. And what this would do is give the same flexibility. It would make the home an eligible originating site for telehealth services to diagnose, evaluate, or treat mental health disorders on or after the end of the public health emergency. And the end of that's not really that important because they're covered right now as on a temporary basis during the public health emergency. And this is just says, even after that goes away, it would be covered on a permanent basis. So right now it's covered, and it would continue to be immediately after the PHE. The geographic restrictions to provide telehealth for the diagnosis, evaluation, or treatment of a mental health disorder, not necessarily co-occurring with substance use disorder, would have no geographic limits like we have for traditional telehealth. So home is an eligible originating site, no geographic restrictions for those. Okay. Gets more complicated. So with these, in the statute that Congress passed, there has to be an in-person non-telehealth service within 6 months of the very first telehealth visit for mental health services. And that's something that Medicare doesn't really have the flexibility to change because that's in the statute. But after that, the statute has this language that, and periodically afterwards, the department or Medicare can determine the frequency of in-person visits after that may be required to continue to cover these mental health services as telehealth at home, regardless of the geographic area. So that's something that's kind of up for grabs in the final rule, how often that subsequent in-person non-telehealth service should be. The proposal is every 6 months. What I'm hearing from the mental health provider community is that that would be a difficult requirement to comply with. That may not be reasonable. It kind of seems arbitrary. So if you're a mental health provider, if you provide telehealth services via mental health services via telehealth and have thoughts on that every 6 month requirement, I would encourage you to submit your comments on the proposed rule related to that. When those requirements are met, these telehealth services for mental health conditions can be delivered via audio only. They don't have to have that visual component, but there are some restrictions to that I'll talk about in just a minute. So I'll pause there because I've gone through about 15 different requirements on one service. See if we have any questions. None yet? Okay. So let me go to the audio only component of this, where Medicare is proposing to continue to allow certain mental health services via telehealth to be done via audio only. And what Medicare has been looking at as we have the flexibility for certain services right now during the public health emergency to be delivered as audio only versus audio visual. Medicare has taken a look at those claims for audio only services and found that the vast majority of those involve mental health diagnoses. And for other types of services that were not mental health conditions, Medicare saw a big spike around April or May for audio only services, but then it kind of bottomed out or flattened out. However, mental health services, the volume and the frequency of audio only has continued. So Medicare has taken that to mean that this is a demand, it's a service that's being used and may have some benefit to continue to cover on a permanent basis. So the conditions to be able to do that are one, it would have to be an established patient to do an audio only visit. I'm going to go back one slide here. That's probably not too significant because in order to do a telehealth service to a patient, mental telehealth service to a patient at home and outside of a rural geographic area, you already have to have an in-person non-telehealth visit within the previous 6 months. That would make them an established patient. We can have the originating site be the patient's home for these audio only services. Here's where I think the criteria get a little bit dicey. And I'll talk about why. In order to do the service as an audio only and not have video, the patient has to be unable to or unwilling to, doesn't have access or doesn't want to use video. When I read that requirement, my mind immediately goes to how you would demonstrate that in documentation. And that tells me that every note that was for an audio only service should have some indication about the patient not wanting to, not having access to, or unable to use video. And that need to be in the documentation. The provider rendering the service must have the capacity to use video if requested or if needed. And Medicare is considering whether providers would have to add a modifier for mental health services via telehealth delivered as audio only, where that modifier would certify compliance to all of these requirements. I know my thoughts as I read the rule was that I don't like the idea of a modifier certifying compliance, because it makes it, I don't even know how you logistically implement that without manually reviewing all of the notes to determine if that modifier is appropriate. So what we're going to be looking for in the final rule on this topic are the documentation requirements that Medicare would expect to see to provide a service as audio only. Medicare is also considering whether they would limit the level of service that they would allow. So, for example, if this were an office visit, Medicare is considering whether they should limit the level of service to lower levels like 1 through 3. I'll give you my personal opinion. I welcome thoughts, feedback, other opinions on this, but when providers are rendering these services as audio only, I imagine that time is likely the driving factor for the level of service, rather than, complexity of history exam and decision making. So I can't think of a reason, if time is the driving factor, that we should limit the ability to have an audio only service to a 15-minute visit, to a 20-minute visit, instead of allowing longer visits for that. So if you've got anybody wants to submit something in the comments or share their thoughts, I'd be interested on that. My suggestion and feedback with the associations I've worked with has been to leave that up to the provider and their professional judgment on whether the complexity and the time required is appropriate via audio only, rather than imposing strict level of service limits. Medicare is also considering excluding, meaning not allowing audio only services if psychotherapy add-on codes are being used. It's just a consideration that's not been formally proposed, and considering whether audio only would be an option if a crisis code is reported. And I'd also really appreciate the thoughts or feedback on anybody that provides mental health services on that component. As I was researching that last piece, it seems that crisis intervention can be effectively done through audio only, and often is done through audio only with crisis hotlines. And so my thought that I would contribute potentially as a comment on that is that audio only should still be available, even if the crisis intervention add-on code is reported with the base service. Any thoughts or questions on audio only? None yet? All right. Right, so Medicare, as part of the public health emergency, created this add-on code So we already have a code for communication technology-based service. You'll see that like a virtual check-in, and the virtual check-in service is to have a brief communication with the patient to determine whether there's a need for a full evaluation and management service, an office visit or a telehealth service. And when that check-in with the patient is not related to an evaluation and management service in the previous 7 days, and it doesn't lead to an evaluation and management service at the next soonest available appointment, then you can bill for that time to check in and determine if the patient needed a visit. So we already have a code for communication, this virtual check-in for up to 10 minutes. I think I say that I think it's 5 to 10 minutes of time for that check-in service. And Medicare is finding that sometimes that check-in service takes longer. So they created temporarily a service for 11 to 20 minutes of virtual check-in time. And Medicare would make this code and payment for these longer durations of virtual check-ins available on a permanent basis. I don't see anything terribly controversial about that proposal, and that's something that I don't gamble very much, but if I did, I would say that's probably going to be something we see in the final rule that's passed. Any questions on the virtual check-in services? Okay. All right, so I want to talk about evaluation and management services, and the proposals that I'm going to talk about apply whether or not they're delivered as via telehealth. Okay, so one of the rules, as a background, by way of background, there are internet-only manuals on Medicare's website, and they have long been kind of like the Bibles of Medicare coverage for different types of services. And the claims processing manual, it's manual 100-04, chapter 12, is where we find much of the rules for physician and professional services, and all of the kind of nuances and details on when they are covered and how they're covered and when they're not, and some specific rules. There has been a growing trend to scrutinize policies that Medicare has put in manuals that have not gone through the rulemaking process. So what I'm talking about today, this proposed rule, it gets published in the Federal Register. We have an opportunity to read it, to consider it, to think about it, to submit comments, questions for clarification, agree, disagree, etc. And then Medicare takes that and will finalize a rule or withdraw its proposal or change its proposal. But a lot of the things that we see in the manuals are kind of administrative guidance, but they have been taken and implemented and interpreted as if they are law, but often have not gone through that same rulemaking process. And there's a significant trend to scrutinize those types of policies that never went through rulemaking. And there's this concept in billing, evaluation, and management services called split or shared billing. And this is when a non-physician practitioner and a physician within the same group practice both provide services to a patient on the same day. And there have long been what are called split or shared rules to determine when and how that visit could be billed under the physician's name and number as the rendering provider. And the significance of that is that when the physician can bill these services under his or her name or number, it's paid at the full fee schedule rate instead of a discounted rate for non-physician practitioners. What was in the manuals for years and years and years is that the ability to do a split or shared service was limited to established patients, and to bill under the doctor's name, it had to be, the physician had to provide a substantive portion of the visit. And that term substantive has just long been a source of ambiguity and problems from coding, billing, compliance, and audit perspectives. So then we had these regulations that have come out recently called Good Guidance Regulations. And basically tells all the federal agencies, if you've got policies, they need to go through the rulemaking process. And there was a petition from the Department of Health and Human Services to remove these provisions in the Medicare manual related to split and shared billing because they had not gone through the appropriate rulemaking process. So that petition happened early last year. They were removed from the manual in May. So as of right now, we have no rules, restrictions, or requirements telling us when non-physician practitioners and doctors both see a patient, when and how to bill those. But we did see that in the proposed rule potentially going into effect for beginning January 1st, 2022. But they are a little bit different than the rules that we're used to. So I think these can be really important from kind of a compliance perspective because I see some problems and I see some challenges that I think we will see addressed in the final rule. Medicare would propose to define a split or shared visit as one in the facility setting. So this would be nursing facility, it could be a surgery center, hospital outpatient, hospital inpatient. It would not apply to non-facility settings like the provider office. So an E&M in the facility setting performed in part by a physician and a non-physician practitioner, like an APRN, physician assistant, who are in the same group practice. Right now, that generally means the same billing group, tax ID for the billing group, and otherwise in accordance with laws and regulations. So the service has to be within the scope of practice of all of the providers and so on and so forth. Some changes that we would see if the proposals are finalized is that these would be available for new and established patients. I think that's a positive. I think it reflects the way care is currently given in the facility setting, and that creates an additional flexibility. It avoids a challenge that we always had with an initial hospital visit when two providers saw the patient on the same day. So that's a positive. It would be available because it's available for both new and established patients in the facility setting. It would be available for the categories of codes describing both initial and subsequent visits. So initial hospital care, subsequent hospital care, initial observation care, subsequent observation care, initial nursing facility care, subsequent nursing facility care. It would also be allowed for critical care services, and previously critical care services were not allowed to be provided, or I should say billed, as a split or shared service. One individual practitioner giving critical care to a patient had to meet all of the time requirements, and if they weren't met, you couldn't combine the time of team members within a group practice to bill. All of those so far, I think, are positives. What Medicare would propose in determining as being the determining factor in whether a physician could bill for the split or shared visit is the substantive portion would be defined as greater than 50% of the time. And that, I think, creates some challenges because right now it's atypical for the non-physician practitioner and the physician to document their respective times. They are often selecting their levels of service based on history, exam, or decision-making. The way this is written, basically every provider in the facility setting will have to start documenting time, particularly non-physician practitioners, in the event a physician were to come by later that day. If we wanted to bill under the doctor, both providers would have to have time documented to show that the physician was greater than 50% of the time. I also think that's challenging because it's not consistent with the way split and shared visits are described in the CPT book. Under Medicare's rules, Medicare's proposing a structure and only contemplating one doctor and one non-physician practitioner. And while that's probably the most frequent way that these are used, CPT allows it for multiple, any combination of physicians and non-physician practitioners in the same group practice. And under this proposal, where the substantive portion is greater than 50%, if I have 3 providers in the same group practice who see a patient in the day, nobody can render greater than 50% of the time, right? So we would be forced to bill it under the non-physician practitioner's name and number. Let's see. Only distinct time, that makes sense, could count towards selecting the level of service. So if doctor and non-physician practitioner are in the room with the patient at the same time, we can't count both of their time towards the level of service that we eventually bill. And that would need to be a pretty significant educational component for the providers. Not only do you have to document your time on basically any note where a split or shared service may be possible, but you have to make sure the time you're documenting is only your distinct time and not any that was rendered concurrently with other healthcare providers. Watch for a modifier in the final rule. I'm hoping this doesn't happen. I don't know what was going on in the proposed rule this year, but it's like Medicare wants a new modifier for everything this year. And the comments or the feedback that I've been suggesting is not to have a modifier to indicate when a split or shared visit was rendered. We've never had that in the past, but to continue to finalize whatever rules they're going to finalize, and we wouldn't need a modifier to identify those services. For critical care services, there are a lot of changes for these in the proposed rule that I think are generally positives. For example, total duration of time would continue to be required because these are time-based codes, but Medicare would no longer require start and stop times for critical care, making it a little bit easier to support these if they're reviewed. Would allow critical care to be done concurrently, meaning multiple professionals in different specialties could deliver critical care. That I think is important because we often have pulmonology, infectious disease, and various specialists helping when a patient is critically ill or injured. All providers in the same group providing critical care to a patient on the same day could combine their time. I think that is a huge positive, because right now, or I guess I should say before May 9th of 21, when these rules were taken out of the manual, a single individual practitioner had to meet all of the time requirements to be able to bill critical care and couldn't combine their time with others. So that would give providers greater flexibility to capture the time within their group. Let's see, provider reporting more than 50% of the time bills. I had the same comment or reaction to that as with split or shared. If we've got 3 providers delivering critical care within a group, no one of them would be able to render greater than, or may not, I shouldn't say cannot, may not render greater than 50% of the time. So we need the flexibility to decide who would bill for the services in that circumstance. Now, another new thing for critical care that has not been done in the past is in the proposed rule, Medicare said they would bundle the payment for any critical care occurring in a post-operative period of a surgery into payment of the procedure and would not pay for that separately. So any procedure with a 10-day global period, which are usually, think of like lesion removal procedures, things that are done in the office as minor procedures, or 90-day global periods, which are major procedures, could not have critical care billed in the post-operative period by a provider of the same specialty in the same group practice. And I think that could be a challenge. Let me pause there. Any questions on the proposals for split or shared services or for critical care services?
I know this is overwhelming, but also you're explaining it very clearly. It's just a lot of different things, isn't it?
Say that again, Robert.
I was just saying it's a lot of different things, but you're explaining it clearly. A lot of changes.
It's, yeah, a lot of really technical changes. What was the thing that really stood out to me this year? That all of these requirements have to be met to bill something a certain way, and some of these provisions for split and shared and for critical care have been really ingrained for really like decades, and would represent a significant change, a lot of provider education, a lot of compliance and internal audits and monitoring to make sure we're addressing the new rules and requirements. And that training and education component was, in my opinion, really not taken into account on the financial analysis portion of this rule, where they look at how much training and education would be required. So it's, yeah, I think these would definitely be significant. Now, the last one that I wanted to cover this afternoon is that we've got a flexibility right now during the public health emergency on the idea of direct supervision, that can be provided via virtual presence. So direct supervision means procedures or services that require that level of supervision. And there's 3 that Medicare recognizes, I guess. So let me back up and I'll talk about those 3 levels. There's personal supervision. So items or services that require personal supervision need the supervising provider to be in the room physically present when that service is provided. We know the level of supervision from the Medicare resource-based relative value system files that are also published on Medicare's website. And it's a spreadsheet. And for every CPT or HCPCS code, they've got all these indicators, and you can scroll across to the supervision column. And there are indicators of like 1 through 99 that have different supervision meanings. And then there's a file that tells you what all of those mean. So personal supervision is kind of the most restrictive, the greatest level of supervision. Then general supervision is on the other end of the spectrum and doesn't require the supervising provider to be in the room and immediately available. When you think of some of our care management services like chronic care management and transitional care management, where we have clinical staff doing things for the patient kind of behind the scenes that are not face-to-face, those are allowed via general supervision. The supervising physician or provider does not have to be in the room or even in the same physical office suite or location where the clinical staff member is who's actually providing that service for the patient. So the one in the middle, direct supervision, previously requires that the supervising provider is in the office suite and immediately available for the professional who's rendering the service, and can intervene if necessary. When we have in the office setting, if you have nurses doing blood pressure checks and you bill for those under the physician's name or number, the way that we can do that is that the physician is in the office suite immediately available, directly supervising the nurse doing that blood pressure check or the nurse doing the ProTime clinic. So that, and direct supervision would be required. During the public health emergency, that in the office suite immediately available, that presence requirement has been relaxed and can be met through virtual presence, which means instead of being in the office suite immediately available, the provider, as long as they are available virtually through like audio visual, almost like a telehealth type service technology, could they get on FaceTime and be available to assist if needed? That meets the requirements of direct supervision through the PHE. So right now that's covered through that virtual presence flexibility to meet the requirements of direct supervision will extend through the end of the calendar year when the public health emergency ends. So at least December 31st of this year, probably through at least December 31st of next year, but Medicare is considering whether to make that a permanent flexibility, and whether that needs to be allowed only for a certain subset of services whether to have a modifier on the claim forms that go with it to indicate that or certify that virtual presence requirement was met. It would audio only presence is not allowed. So the supervising provider has to be able to intervene with audio visual services. And with smartphones, as long as you could FaceTime or some kind of audio visual communication, that generally can meet the virtual presence requirement. So any thoughts or questions or feedback on whether Medicare should extend virtual presence as a way to meet the direct supervision requirement, or how that affects some of the services that you provide? While we wait, if anyone has questions in the chat, I'll add that one of the ways that this directly affected telehealth in the last year is that it was never really clarified that telehealth can be rendered what's called incident to the services of a supervising physician, meaning could it be done, could that the telehealth equivalent of an in-office blood pressure check or ProTime clinic check be done via telehealth? And Medicare clarified that there's nothing prohibiting that, meaning those telehealth services that may be rendered by clinical staff could potentially be billed by the supervising physician if incident to requirements are met, which requires an initiating visit where the provider orders or makes that service part of the plan of care, but also when that telehealth service is delivered, to bill it under the supervising provider, there has to be direct supervision. Well, during the public health emergency, supervising provider may be at home during quarantining, but still available to intervene, or the nurse providing the service may not be in the same physical location. And that's how this virtual presence flexibility to meet the direct supervision requirement came about, and how that would impact billing on telehealth services.
I wondered about supervision of nurse practitioners and PAs, as well as, I know one of the big changes they made was the allowing supervision of medical students through tele. Is that all still, would that be in this, or is it still going to be allowed, or they're considering allowing it after the emergency? I'm just wondering.
Yeah, so there was a section on teaching physician services, and then the rural health exception. I'm not sure if I'm preventive health exception, allowing residents to provide certain primary care exception is what I meant to say, excuse me, allowing residents to continue to deliver primary care services and the circumstances for that. The proposal is that would still be allowed, that however, the residents, because we can select levels of service based on key elements of history exam decision making or time. And if they're selecting their level of service on time, Medicare is concerned they may be overpaying because residents inherently may take longer to provide the same service. So Medicare was suggesting that would continue, but the residents must select their level of service based on key elements, not on time. And we're continuing to allow flexibilities for the teaching physicians under the primary care exception, would continue to allow residents to deliver all levels of care until the end of the public health emergency, and then would revert back to levels 1 through 3.
That's excellent. I don't know, I know we have a couple more minutes. I don't know if you had anything else to go through, or
that was the last one. So I'll open it up for questions, comments, complaints. Remember, I didn't create the proposed rule. I just share the message.
Rick Warren indicated that he supports the indirect supervision through telehealth. So
yes, I think if you've ever had the fortune or misfortune of trying to read and interpret incident to billing rules, proving that the supervising provider whose name was on the bill was in the office suite and immediately available is really difficult during a review. And that virtual presence flexibility on a permanent basis, I think is going to make that much easier for providers and make those services less of an easy target for medical review and audits.
And while we wait to see if we have any more questions, we just have a minute left, but please, if we have another question, we're happy to answer it. I do want to thank everybody for participating today. We had great participation, as well as remind you that if you have questions or you need clarification, I know we covered a lot today, please, you can go to our website, htrc.org. You can certainly email us, and Christy can tell you the email address because I can never remember it. And we're always available to answer your questions, and Rochelle is always available as well. Christy just put the email in the chat, which is htrc@kumc.edu. But we're here for you. I know we cover a lot during these presentations, try to get all the content out there. As you need clarifications, we always get lots of questions after these, and that's exactly what we want. We want those questions. We're happy to clarify. Rochelle loves answering your very detailed, very complex questions. She's a lawyer.
I do. I love it. I love reading these 1,800 pages, and I will take that burden off of you. And
I'll give everyone a challenge. Try to stump Rochelle because I haven't seen her stumped yet.